This session is on how we think. It sounds like something that's not immediately relevant to emergency medicine in the sense that it's not. It doesn't sound very dramatic or life-saving, but in fact, how we think is probably the most important thing that you do in all areas of medicine, but especially in emergency medicine. And emergency medicine has probably served as the platform for getting this material into the medical curriculum generally. It's said that the environment, the emergency department, is actually a laboratory for the study of human error. In particular, the thing I focus on is the way that people make decisions. Still concerned you're not hearing me. Derek, can you hear? Yep. Yep. Okay, so we're going to spend the session just talking about thinking, and I'm going to try and persuade you that this is really the most important thing that you do. And you knew that anyway, but we tend not to focus on it. So we're going to start with a little quiz. Just take a piece of paper, write your answers down to these questions. They're going to come at you fairly quickly, which is how things happen in emergency. This is real life simulation exercise. And just record the answers for your own benefit. There's no evaluation on your responses. Okay, here we go. The first one is, on a standard London fire truck, there are 2 drivers up front, 1 at the rear, and 3 additional firefighters per truck. How many people do you need for 5 trucks? Don't look at this too long. 2 up front, 1 at the rear, 3 in the middle. How many do you need for 5 trucks? Okay. The second one is a syllogism. That's 2 premises followed by a conclusion. And it says, all living things need water. Roses need water. Therefore, roses are living things. Is that conclusion valid or not? The third one, this guy's running along with a ball, and he drops it. I'm sorry, the slide's got a bit fragmented there. But he drops the ball, you can see what happens. And you have to decide whether the ball actually goes backwards, that's C, drops straight down in a straight line, that's B, and A is continues forward on a parabolic trajectory. A, B, or C. Next one, a bat and a ball costs $1.10 in total. The bat costs $1 more than the ball. How much does the ball cost? Pretty easy, isn't it? Which is correct? The Earth moves around the sun, or the sun moves around the Earth? We've been here about 6 million years on this planet. We should know this. The next one, if it takes 5 machines 5 minutes to make 5 widgets, how long would it take 100 machines to make 100 widgets? In a study of 1,000 people, among the participants were 5 engineers and 995 lawyers. Jack is randomly chosen. He's 36. He's unmarried, somewhat introverted, likes to spend his free time reading science fiction and writing computer programs. What's most likely? Jack is, I don't know why this always attracts laughter, but why is, what's most likely, Jack's an engineer or Jack is a lawyer? And finally, in a lake, there's a patch of lily pads, and every day the patch doubles in size. If it takes 48 days for the patch to cover the entire lake, how long would it take for the patch to cover half the lake? Okay, so those are 8 questions, with the exception of the first one, which was actually just a straightforward calculation, the number of guys on the fire truck. The correct answer was 30. 30 personnel for the fire truck, that's a straight calculation, and it was just to warm your brains up a bit. That syllogism, the 2 premises followed by the conclusion, was invalid. We can go into that if we've got time. The ball falls straight down, It does not continue forward in the parabola, does not go backwards. The ball costs 5 cents and the bat costs $1.05. Most people will put $1 for the bat and 10 cents for the ball. The Earth moves around the sun, even though we say each day the sun rises in the east and sets in the west. In actual fact, the sun is being circled by the Earth. 5 minutes for 100 machines to make 5 widgets. 5 minutes for 1,000 machines to make 1,000 widgets. Most people will put 100. Jack is a lawyer. When you're given that small bit of information, he's introverted, likes science fiction, unmarried. For some reason, that makes people think of engineers. I'm not sure why, but your intuition says engineers. But the statistics, it's vanishingly unlikely that Jack will be an engineer. There's only 5 out of 1,000. It says he was randomly chosen. And then you're just given that little bit of information. It's enough to persuade you intuitively that I know who Jack is, but you would be wrong. And if the lily pads are doubling every 24 hours, they had to be half that the day before. And most people, again, will put 24. They will halve the 48 days. So the 8 items on the quiz are basically designed to look at your intuition. And most of you will have got most of those questions wrong. And yet you'll admit that they're really not difficult questions. But just intuitively, you have a tendency to respond to the answer, which is usually incorrect. And just to make you feel a bit better, sorry, I've never had this happen before. About half of people will say that the ball actually goes forwards in a parabola there. So about half of people get that wrong. 3 of the items of those 8 are something called the cognitive reflective test that was developed at MIT by Shane Frederick. And the test distinguishes between intuitive and analytical processing, these 2 ways of reasoning. This is called dual process theory, and all people think this way wherever you are on the planet. We all engage in this 2-process way of thinking. And essentially the test tests your ability to resist the first response that comes to mind. In Frederick's study, he tested 3,500 people. Only 17% got all 3 of those items correct. We give the test to the incoming class at Dal each year. We get maybe 2 out of 100 get all 3 correct. It's got nothing much to do with intelligence at all. It's got a lot to do with the way you tend to think. And 33% in Frederick's study answered all 3 incorrectly. So it sort of leads you to think about how people think. And we did a study which involved 3 emergency departments, and we just asked the emergency physicians, what do you think the most important characteristics of a successful, well-calibrated emergency physician are? And people, in their responses, people said, well, you've got to be a good team player. Gets a lot of emphasis. You've got to be good at decision-making, got to have stamina, reliability, procedural skills. You've got to be good at putting in central lines, doing casts, doing LPs, and so on. Good attitude. Good bedside manner, communication skills, knowledge, consistency, motivation, temperament. But the 2 that came to the top, when we asked people to rank the top, we actually asked them to rank the top 3. But the top 2 were decision-making and knowledge. How you make decisions and what your knowledge base is. If you don't have an adequate knowledge base, obviously you can't make effective decisions. But emergency physicians value decision-making very highly. And it really isn't a matter of not knowing enough. Most people graduating from medical school have an adequate knowledge base. If you don't, you can quickly access it these days. The main issue is how we make decisions. So there are 2 main areas of decision making. 1, making the diagnosis, and 2, managing the patient. And despite this being arguably one of our most important skills, if not our most important skill, In fact, most doctors consider this the most important. If you admire a colleague for what they do, often it's because they're good diagnosticians. Most of us regard it as the most important ingredient in our self-image. So how well do we do with it? Any guesses across the board what the average diagnostic failure rate is? Just put your hand up if you think it's 1%, 5%, 10%, 15%, higher than 15%. Yeah, the best estimate is somewhere in the range of about 15%. My department sees about just over 100 a day. It's a fairly small department. But it's a little frightening to think that we may be getting it wrong about 15% of the time. And it varies throughout medicine. If you're in one of the visual specialties like radiology, dermatology, anatomic pathology, say, your failure rate in diagnosis is around about 2 to 3%. If you're in emergency medicine, internal medicine, family medicine, probably up around 15%. And the Institute of Medicine, who are the people in Washington who brought you the big patient safety reports and so on at the turn of the century, they are now working on this, and there will be an official publication from the IOM next year on diagnosis. And I think it's going to change, probably will influence the course of training in emergency medicine. Diagnostic error. In the major medical patient safety studies that were done in the 90s, 80s and 90s, it was found to be the second cause of adverse events. It probably would have been first if they had better methodology for doing those studies. There is a consistent discrepancy with autopsy findings over the year of about 20 to 30%, 40% in some series. That is, the thing that you thought that people died of, their ante-mortem diagnosis does not match the post-mortem diagnosis. And it said that a third of all autopsies would not be taking place if the correct diagnosis had been known. In terms of specialties, emergency medicine, family medicine, and internal medicine are the ones that are the highest. And they're the ones where you would think that people are doing the most thinking, the most reasoning and problem solving. Things like dermatology, radiology is a more pattern recognition type of skill. But you have to do a bit more thinking in those disciplines. In the UK, it's estimated that 30% of preventable deaths in the country are due to diagnostic failure. In the US, 40 to 80,000 deaths annually. This is probably much higher. That was an estimate back about 10 years ago. The latest stuff is suggesting more like 100,000 a year. 50% of all closed medico-legal claims in the US are from diagnostic failure. I have data from the CMPA, which summarizes a 5-year period, which shows that they broke medico-legal claims down into 6 major areas. Diagnostic error was one of them. Diagnostic error is number 1 and is higher than the other 5 categories combined. So for the CMPA, this is quite important. 2/3 of all claims against UK family doctors are for diagnostic failure. And in one study of 122 closed cases, almost half resulted in serious harm and 40% in death. A Taiwanese study found that almost half of preventable deaths within the first 24 hours of being admitted from the emergency department were due to the wrong diagnosis. And then a study that was done in Ottawa, which looked at the top 3 acuity levels, the CTAS levels 1 to 3. 20% of emergency adverse events were due to diagnostic failure. So there is a problem. I mean, it is overwhelmingly clear that we do have a problem with diagnosis. And it's not surprising that we get it in emergency medicine. It's a difficult decision-making environment. There is high decision density. People suffer from decision fatigue, throughput pressures, wide ranges of illness. Just about anything can turn up there. Diagnostic uncertainty is high. There are very narrow time windows to assess patients. We get frequently interrupted and distracted. We have shift work for most of our careers. And just very approximately, the cognitive decline that you suffer during the course of a night shift probably amounts to about 30% by the time you're ready to go off in the morning at about 6 o'clock. If you do psychomotor tests on people coming off night shift, they've got about a 30% decrement in their ability to think. Of course, a lifetime of shift changes. There's a study I've just reviewed it, but it's not yet published, which actually looked at the different areas in the emergency department where there was where they could measure diagnostic failure. Radiology came out at 5%, missed injuries 12%, cardiovascular misdiagnoses almost 20%, and respiratory 30%. Overall, about 16%, which fits the general number that's being circulated. So mostly, it's not about what we don't know, and this, people have written about this in the literature and said, well, the reason that doctors get it wrong is they just don't know enough. And that really is not the case. We tend to miss common things. We need to know more about how we think. This area generally has attracted interest recently. There's 2 books on thinking. Malcolm Gladwell's book on the left. Anybody read that? And it was on the bestseller list for a number of years. Malcolm Gladwell's a journalist, but he knows enough to exploit psychology. There's quite a bit of the psychology literature influenced how that book was written. It's not a very good book. I could get sued for that, but the content of the book has been analyzed by psychologists, and they've said, you know, this is not a fair comment, this is not a fair summary. He is something of an opportunist, but it caught the public imagination, and the psychologists actually say that what he was advocating in the book, the subtitle is The Power of Thinking Without Thinking. So he was advocating for intuitive thinking, this sort of shoot from the hip stuff, trust your intuitions, but in fact it's a very dangerous place to be. And you'd be surprised how much time you spend in that intuitive mode. And all of the 7 of those 8 questions that you got at the outset were really testing your intuitions. This book on the right by Michael Legault, he was a sub-editor for the National Post. And his subtitle was Why Crucial Decisions Can't Be Made in the Blink of an Eye. And it was written as a direct foil against Gladwell's book. This book on the right is virtually unknown, but it's actually quite a well-reasoned and legitimate discussion of thinking. This is not, but this makes money. This doesn't. People like to hear about how good their intuitions are. 2 books in medicine came along in the first part of the first decade. This came out, How Doctors Think by Catherine Montgomery, came out in 2005. She's a bioethicist from Chicago. This is a really good book, very well thought through. She's not medically trained, but she knows an awful lot about how doctors think. This book by Jerry Grootman, How Doctors Think. Anybody read that one? Yeah, that really is. What he did, he's a Harvard-based oncologist, and what he did was just trawl the medical literature for failures in medical reasoning, and they are abundant. And this book was a bestseller. So what do we know about how we think, reason, and make decisions? I never took a course in clinical decision making. As an undergraduate, I took courses in logic and reasoning and so on. But is anybody here taking a course in how you make decisions in emergency medicine? Or in any kind of medicine, in your undergraduate medicine? Did you ever do this? So do people find this odd? That this is, a lot of people say this is the most important thing that we do, and yet we don't get any training in it. It seems odd. Okay. What it comes down to is this. We make decisions in one of 2 modes throughout healthcare, whether you're a nurse, a paramedic, an emergency physician. When we think of thinking, we think of rational thinking. We think of this slow, deliberate process that's objective, scientific, and makes very few errors. That's what we think of as thinking. Whereas a lot of the time, we're actually spending in this intuitive mode. This is a fast system. It's autonomous, which means that your brain doesn't even consult you when it makes a decision. We'll talk a bit about that. It's highly context-dependent, qualitative, and it's prone to errors. So in my department, say I'm standing at the nursing station, the triage nurse comes in my department, they will actually bring the patients in. Guy's in a wheelchair, he's about 60 years old, he's got flank pain, he's got a basin that he's vomiting into, and as she goes by, the nurse waves his urine at me and says it's positive for blood. You have no choice there. Your brain will make, in Atlantic Canada at least, your brain will make the decision that this guy's got a kidney stone, just as he's going by kidney stone, like that. And your brain doesn't consult you about that decision. It makes the diagnosis. And some people, if you are strongly intuitive, will tend to persist with that initial diagnosis. And yet, the more calibrated thinker can pull back from it and say, yes, it's flank pain, hematuria, nausea and vomiting in a 60-year-old, could be dissecting his aorta. And I've actually seen that about 3 times, where they have been labeled as renal colic coming into an emergency department. So the art, if you like, of critical thinking is the ability of the rational mind to, and they are plumbed separately, your rational mind to observe what your intuitive mind is doing. And this whole thing is called dual process theory. It's the dominant theory of thinking. It's been around since the mid-70s. This is Daniel Kahneman. This is his. He's a Nobel Prize winner in decision making. He's at Princeton, and he wrote the book Thinking Fast and Slow. It was published about 4 years ago. Was a bestseller, and he really talks about these 2 processes: analytical thinking, which the psychologists refer to as System 2, and intuitive thinking, which is called System 1. So this is a good read. It's a bit depressing at the end of the day because he, again, like Grootman, talks about all the failures that we exhibit in thinking. So this is called dual process theory, and we actually know where these things are in the brain. Most of System 1, the intuitive system, is located in the old brain. This is a ventral view, that's a lateral view. X1 is ventromedial prefrontal cortex, nucleus accumbens, amygdala, and sort of inferior lateral cortex. That's all System 1. You can show this from functional magnetic resonance imaging studies. System 2, the kind of modern brain that's evolved over the last maybe 200,000 years or so, is prefrontal cortex. Hippocampus is old brain, but still functions here, and posterior parietal cortex. And there are some awful lot of interesting work going on now trying to identify which parts of the brain are involved in different parts of the decision-making process. We summarized it in this model. This is called the dual process model of clinical reasoning. This was published in Academic Medicine. The patient, it's a linear model, goes across the page from left to right. The patient presents here with their symptoms and signs. So in the case I just gave you, nausea, vomiting, flank pain, and your brain, as with all mammalian brains, is a pattern processor and looks for patterns all the time in your environment. If it recognizes the pattern, you go into the intuitive mode. This is multi-channeled. We'll probably say a bit more about that in the workshop later. But this intuitive mode is extremely fast and can give you the diagnosis in milliseconds. If you don't recognize the pattern, you go into this System 2, the analytical mode. This is slow, deliberate. This could take you several days to actually get the diagnosis. Somebody comes in with atypical chest pain. You start the workup, they end up with maybe getting an angiogram and so on. And it may take a few days before you actually get the result. So it's a dual process. This is one process, intuition. The other process is analytical thinking. If you keep, and I'll just give you a quick example of of that. For example, everybody's got that diagnosis immediately. You actually got it in about 300 milliseconds. When you were a medical student and you were asked what this was, when you hadn't any prior experience with that particular pattern, you would say, well, patches of erythema, clusters of vesicles, seems to follow a dermatome and stops at the midline. And then later on, it's shingles or herpes zoster, and that's it. You don't do any thinking. And that happens extremely quickly. So you go from seeing that pattern to shingles in a third of a second. And you've got the diagnosis right most of the time. Not always, but most of the time. If you keep presenting things in the analytical mode, you end up in the intuitive mode. So say, for example, just in the acquisition of a skill like intubation, the first time you are exposed to intubation, it's a completely alien thing. You look in, you have this instrument there's nothing intuitive about a laryngoscope. Some people would be more comfortable opening a bottle of beer with it. But it folds the wrong way and so on. I've seen the cartoon on that one. But after 40 hours of doing that, of going somewhere where you haven't been before, you end up in the intuitive mode. So most skills can be, the steep part of the learning curve can be accomplished within about, say, 40 hours if you're learning to sail, if you're learning to skate, if you're learning to intubate, if you're learning to be a barista at Starbucks. It's all done in about 40 hours up the steep part of the curve. Your System 2 can also override System 1. So if my brain says the guy's got a kidney stone, System 2 can say, yeah, looks like a kidney stone, but we have to check a few other things out. So that's called executive override. There is this T here implies a toggle function, which means you can move backwards and forwards between System 1 and System 2. And people say, an internist friend of mine says, I get all my ideas in System 1 and I test them in System 2. System 1 is a place for inspiration, creativity, lateral thinking, and so on. But you can't stick with that. You have to make sure of the validity of those guesses. System 1 can override System 2. That's called irrational behavior. Despite knowing what the best thing to do is, you still follow your intuitions. We've all done that, and we'll all continue to do that. And then the final property is that the whole model, and we'll talk more about this later, has a tendency to default into System 1. That's called the cognitive miser function. Your brain will try to get to System 1 whenever it can because it's a comfortable place to be. You don't have to do any thinking if you're in System 1. Pink Floyd called it being comfortably numb. Okay, so here's the acquisition of a skill. You come into system, this is just the front part of the diagram blown up. You come into System 2, you start off as a novice, you progress to advanced beginner, competent, proficient, and hopefully expert, and then you end up in System 1, doing those things reflexively, without any thinking. And that's just the simple acquisition of a skill. And this is a nice demonstration of it. These are actual views of the brain during functional magnetic resonance imaging in three stages. The first one is novice, intermediate, and skilled. And you can see right at the outset, when the novice sees the problem for the first time, System 2, the frontal part of the brain and the parietal part of the brain and areas of the motor cortex all light up. Tremendous amount of activity going on. Halfway through, this is 30 minutes, a lot of that activity has died down. And at the end of the hour, where here's a skill that can be acquired within an hour, there's virtually nothing going on in System 2, in the analytical brain, the frontal cortex or the parietal cortex. There's just a bit of activity in the motor cortex to maintain the skill. That's a really good demonstration of it. And if you want to translate that into a learning curve, this is what people are talking about. This is the logarithmic scale. So this part here is the initial steep part of the learning curve, about 40 hours, gets you to a level of sort of functional competence. And then, but if you really want to become an expert, you're looking at about another 10,000 hours, they say, of deliberate practice, deliberate professional practice. And this is a slow process. So this takes you from being naive to actually looking as though you know what you're doing. And then the next 10,000 hours is getting better and better at it. Jim Reason translated it like this. If these are, the bit up the top here, the maroon bit, is system 2, analytical thinking. This is system 1, which is the intuitive thinking. And the blue bit in the middle is the application of rules, like clinical decision rules, for example, where you don't actually have to do anything if you want to apply the rules. You're actually applying somebody else's system 2 thinking. It's kind of system 2 by proxy, okay? So if you look at a novice, this is a first-year medical student, 70, or say a third-year medical student, 75% of their time is in system 2, about 20% of their time applying the rules, and about 5% in the intuitive mode. Students should not be in the intuitive mode. They should be almost entirely in system 2. As you progress through intermediate level through to expert, by the time you're an expert, you're 75% of the time in system 1, functioning in the intuitive mode. And mostly competently, but there's always that element of danger when you're trusting your intuitions. And system 2 thinking in experts is down to about 5%, 5 to 2%, 5 to 10%. So that is the basic model now of how we think. And it's a very handy way of teaching people the basics of thinking. In the space of an hour, you can take people from being naive to saying, oh, this is actually how we think. We have 2 modes of thinking. Here are the main features of the model. We spend most of our time in system 1, probably 95% of the time. For all of you who are out of training, you're in system 1. And throughout your daily lives, you're in system 1 most of the time. If you're driving your car, you're in system 1. The first day you get in a car, you're in system 2. You're dealing with all those levers, pedals, switches, and everything. After about 40 hours or so, you've moved more or less into system 1. Most biases are in system 1. Most errors occur in system 1. That's where you spend most of your time. Repetitive operations in system 2 get you into system 1. That's the learning part of it. System 2 can override system 1. That's sort of rational reflection on what you're actually doing. System 1, unfortunately, can override system 2. Many examples of that, just people reacting with their intuitions when they should be doing something a little more thought. There is the toggle function, which allows you to move backwards and forwards, and then the cognitive miser function being comfortably numb. And we know the conditions under which the cognitive miser function especially tends to get engaged. When does it kick in? All the time. Especially when you're fatigued, when you're getting near the end of a shift, when you're sleep deprived, when you're feeling down, when you have a dysphoric mood, your decisions deteriorate. This is all experimentally demonstrated. When resources are limited, when there is overcrowding, all of those things promote being in system 1. And if you're in system 1, it can be a dangerous place to be. System 2 doesn't always make good decisions. Sometimes you just have to go with it. You know, if you start calculating things out, try this on yourself. Just time yourself how long it takes you to do up your shoelaces, and then time it when you're providing a commentary on it and giving a description of each step. And you will slow right down. It's like asking Tiger Woods, can you tell us what's going on when you make your swing in golf? He can't. He can do it, but he can't comment on it very well. He may in a sort of semi-analytic way, but most of the time, just doing something that you're used to doing in System 1 works very well. So most of our time is spent in System 1, the famous iceberg graphic that shows very little of sort of conscious decision making is above the surface. And just test yourself on this on some days. When you get up in the morning, how long is it before you actually do any real thinking? You know, you get up, you turn off the alarm because the clock's exactly where it was when you left it last night. Nobody's moved it, usually. You swing your legs out over the side of the bed. The floor is still at the same height that it was yesterday. You walk across to the bathroom, which hasn't been moved during the night. You know, and I'm being a bit facetious, but so much of our environments are predictable. Driving, complex driving, is predictable. It's a predictable set of skills that we just unravel whenever Kahneman says, whenever the association gets triggered. Out comes the behavior. And that's where we're comfortable being. And we're doing that 95% of the time. I've got all the way into the emergency department and actually seen a couple of patients before I've had to do any thinking. Because after 30 years of looking at ankles, I know what I'm going to do. There's only so many things this can be. And you can routinely check for, check the Achilles tendon, check the proximal fibula, check the base of the fifth metatarsal when they come over there. You can do all those safety checks routinely. It's not even an effort to monitor what system 1 is doing. We're constantly in system 1. It doesn't sleep, as they say. So we have to learn how to deal with it. And I just want to illustrate a couple of things. This is a bar on a background. And the important thing here is the context. The background context is that it's dark on one side and light on the other. And that's how you perceive the signal. The background is the noise. So when the patient is coming in, they've all got a signal that you have to identify. And you've got to be able to disregard the noise. You've got to be able to say, if the nurse says to you as you go to see the patient, this is Mr. Jones, he was in here 3 times last week, we never find anything wrong with him, and so on. And then she might even quote one of your colleagues that you hold in great esteem and say, he got annoyed with him last week and sent him home. But that's all noise. The signal is the patient is there and has some sort of problem. And if you subtract the background, what does the same bar look like when you remove the context? That's what the bar looks like. The bar is still the same signal, but it looks quite different to you. Yeah? Whoops. It is quite dramatic, and nothing has changed. This is PowerPoint. I've just whited out the background. I haven't changed the signal at all. This is really dramatic, but it makes the point about signal and noise. Here's another example. This is an example of your brain not telling you what's going on. This is a checkerboard with a cylinder, and the cylinder is actually casting a shadow. And this is an unusual circumstance because you don't usually see green cylinders on checkerboards, but your brain knows about checkerboards. And the one thing it does know is that every alternating square is either black or white. And so the question for your brains is, disregard everything else that's going on here, disregard the noise. How does the shading of square A compare with square B? Now, your brain will say, A obviously is darker than B, and you can easily see it. But in fact, if you put a grid across the checkerboard, they are exactly the same shade. Your brain may still see them as slightly different, but they are, if you measure them with a photometer, they're exactly the same. So your brain is making adjustments for this shadow that's being cast, and by what your brain knows about checkerboards and so on. What did that say? Yeah, oh, you've all seen it before now. But that was actually the inscription on the pens that were distributed at Bill Clinton's impeachment inquiry. Nothing to do with Bill's sexual practices, his sexual practices, so much as somebody said a Freudian slip, hoping for a non-partisan vote. But your brain will actually compensate for mistakes and adjust them because it knows roughly what the right answer should have been. Go to a different modality, swallowing saliva. You've all been swallowing your saliva for the last 45 minutes. I don't see anybody drooling or... Would you drink a glass of your own saliva? So we're going to present this to you in system 2. We're going to say, we're going to give you a sterile container. You break the seal on it yourself. You salivate into it for about 40 minutes, get about 30 cc's of saliva. We'll warm it up in the microwave to 37 degrees. Would you drink it? No, most people wouldn't. But if we said, we'll give you $25 for doing this. Now, System 2 says, this is safe. It's my saliva. I drink it anyway, all day long. It's sterile. Nobody's tampered with this. I know that this is a safe thing to do, and I can get an easy $25, right? Any takers? $50. And the first people to go will be males on this. No, it's true. And I did a study with Lisa Calder from Ottawa, some of you may know. And we did a study of intuitive and rational thinking in emergency physicians in Ontario. You may have been one of them. And we looked at, if you look at the intuitive and analytical curves, females are somewhat more intuitive than males. And males are somewhat more intuitive, more analytical than females. And it's just different properties based on gender. And it's found every time anybody does this study, but it holds for emergency physicians. And what was interesting was that if you were female and you were trained you were in a Royal College program or Royal College trained, you were less likely to be as intuitive as if you had CCFP EM training. Just one of the things we found in the study. So in that particular example, the emotion of disgust overcomes rational input, and males can deal slightly better with that than females. If you consider that to be something worth dealing with, we aren't asked to do that most days. Here's another example. This is, you're asked to name these words here on the page. So red, green, blue, yellow, pink, orange, blue, green. And if you time yourself on that, it comes out to 12 seconds. And then you do it again, but this time the color doesn't match the word. And what you've got here is two overlearned System 1 responses, the overlearned response of reading and the overlearned response of color naming, and you put them up against each other. And if you now try it, red, green, blue, yellow, pink, it creates a little bit of dissonance in your brain and slows you down. And you go from 12 seconds to about 18 seconds. You do it half as fast. So how do we become better decision makers in emergency medicine? Well, we could tell people to try harder. Most guys I work with in my career have been hardworking. You don't find many lazy people in emergency medicine, so that's unlikely. It's unlikely that it's going to work. One of the problems in studying emergency medicine, I don't know if any of you are familiar with this, but there's a bit of a debate going on in the literature now between people who want to study the kind of decision-making that we do and take this reductionist approach so that you try and eliminate all the independent variables so that you're just looking at decision-making alone. So you end up having people watch computer screens in quiet laboratories sitting by themselves and pressing buttons. And that is how close, the purists think they can get to decision-making. But clearly, it's not what we do. And we feel strongly that you do need ecologically balanced ways of looking at things. On a day-to-day basis, we deal with biases. The human brain is biased, normally biased. If you say he's biased, you usually mean that he's got some particular bias that you've noticed. But your brain operates in a biased fashion all day long. We have information gaps. There are things, we have word gaps. There's things that we often are just not there when we're trying to make decisions. There is an irreducible uncertainty in emergency medicine. Ambient conditions can change dramatically the availability of resources. How you're feeling, if you've just dealt with, if you've just managed a personality disordered patient who has insulted you in exquisite ways that you didn't think were possible, they have PhDs in insulting people. You don't feel very good afterwards, and the evidence is you don't make very good decisions immediately afterwards. If you've just come from a cardiac arrest and the patient died, And then you're immediately asked to see an ankle sprain as your next patient. It's a difficult transition because of just the way you're feeling about yourself. Gender is important, gender of the patient, gender of the decision maker. The personality of the decision maker is important too. You can show, for example, I'm not a fan of the Myers-Briggs personality test, but you can show that scores on the Myers-Briggs in obstetricians determine whether or not perinatal asphyxia will occur. There's a direct relationship between the personality of the obstetrician and perinatal outcomes. And in emergency medicine, there's no question that these things are working on us, but we just haven't studied them yet. We know that there are high-risk situations in the emergency department. Cognitive overloading is probably one of the worst. And you're probably familiar with Mike Schul's group in, where are they now? And the work they've done on on overcrowding in emergency and the outcomes, down the road several weeks later. And there are bad outcomes associated with putting people under that kind of pressure. Interruptions and distractions in emergency are just commonplace. It's how we do business. And yet, people just say, well, that's all right, we multitask. Well, you can hold a number of tasks going at one time, but you can't pay attention to more than one thing at once. It's impossible. But people think they can just keep switching. Every time you switch attention, you have to press the reset button when you go back. Where was I? And the studies show that you lose information there, and your decision-making is compromised. The impact of fatigue, stress, sleep deprivation, negative mood, and the influence of drugs. Cognitive loading increases with the number of decisions you're required to make, with the complexity of those decisions. It raises your level of anxiety if it goes too high. It increases with interruptions and distractions, leads to more defaults to system 1, which experimentally you can show occurs, and it's associated with increased use of heuristics. Heuristics are mental shortcuts, taking shortcuts, and associated with an overall increase in adverse events. You're probably familiar with this. This is the Yerkes-Dodson law. This is stress level along the x-axis, and this is performance level, the well-known curve that where you've got low stress and very little stimulation of your reticular activating system going on, nothing much is happening here, and your performance is actually lower. You notice this in emergency departments sometimes when things suddenly go quiet. They don't normally do that, but people seem to get less efficient when they go quiet. And as you increase the level of stress, there is this good zone here of optimum stress, which you need to get your best performance. As you continue that, you get into high stress levels, and performance actually drops down, and you can even get to a point of panic. Few of us do, just because we've faced it so many times before. But cognitive overload is a real problem. Increased time pressures, decision density, multitasking, fatigue, and stress. What it does is it reduces your cognitive resources, more decisions get made in system 1, therefore they are more biased and more errors will occur. So just to close, there are 10 things I think that adopting this approach can do for us. I think it's really important. At Dalhousie now, we have a critical thinking program where we teach people about thinking in the first few weeks of medical school. They get this right up front. This is how you think, and here's the limitations of the two modes. They do have limitations. You can't afford to be in system 2 all the time. You guys can't if you're experienced, but if you're inexperienced, that's where you should be. So it provides a universal model for describing to people how they think. It's straightforward. It explains how experience leads to automatic, skilled behavior. It explains how impulsive, irrational decisions occur when system 1 dominates, and even dominates your system 2 performance. How impulsivity and irrational behavior can be overridden by system 2. It shows where the biases are. It explains how certain conditions cause decision failures, mostly through cognitive overloading. It predicts cognitively miserly behavior. As I said, you've got a tendency to go into system 1 all the time, but you especially do it under those stressful conditions. And it predicts where weaknesses in the decision-making process occurs. And it generates ideas about where you want to do research in emergency medicine. And I hope some people are inspired by it, because there is evidence now that this is a good approach to take. As I say, some of the stuff that's being done on decision-making, it's a bit artificial, but we will get there. That's about all I want to say on that. I don't know what the time is, but we're probably close to the end of the hour. Do we have time? Do we have time for any questions? Anybody? Yeah.
Has there been any research done looking at the dominance of each system across different medical specialties? Or some more
Yeah.
Versus analytical.
Yeah, I remember in medical school, we all used to think that the neurologists were the most system 2 guys. They're careful, analytic, purposeful, deliberate thinkers, Of course, that's all changed with CAT scans and MRIs. But I'd say you find that, for example, thinking failures, like diagnostic failure, occurs less in radiology, dermatology, anatomic pathology, where people are looking at pictures of things. Once you get involved with patients, the game changes, and all these other variables come into play. And I think that's why emergency medicine has been so active in this area of decision making, because we probably have the worst conditions of all. I'm not saying that because I feel sorry for myself, but emergency medicine really is a special environment for decision making.
So, it was a good talk, thank you very much. I guess we're so worried in medicine about errors of omission, missing something, making a mistake. When we know, I think the data is pretty good that most stuff that comes into emerge, head pain, chest pains, belly pains, ends up being non-specific and nothing. I guess I get worried somewhat that when we do analyze and we start thinking, and we know that patterns don't work for everything, and anything can be anything, we go do more tests, and there's starting to be more evidence out there now with folks like overtreated and overdiagnosed that more medicine isn't better medicine.
Yes.
That leads to deaths. That's why we no longer screen women for breast cancer over 50. Is why we don't. We make mistakes and we hurt people by doing more tests.
Yeah.
And I worry about that. Do you have any comment on that with regard to this, or?
Yeah, I'd like to say that on this Institute of Medicine committee, people are talking about that, the dangers of overdiagnosis, drop the PSA altogether, and so on. And then you ask individuals. I mean, if you look at population statistics, it's a bit different from talking to an individual. And I thought about this. If I go to my family doctor and he says, well, we're not going to do your annual PSA anymore, I'm the individual, and I do happen to know a couple of people whose lives have been saved by doing PSAs. And so I would say, well, do you mind just keeping it going for a few more years? But I think ultimately what you want to say is that what we should aim for in emergency medicine is a well-calibrated physician. And that's somebody who knows when to draw the line on overdoing it in System 2. And as the cartoon showed with snowball throwing, there are times when System 2 is just a failure. You really should stay away from it, and you should trust your intuitions. But how do you find that sort of safe zone where, you think I mean, I have a resident come to me and say, tell you about patient in number 4, this nice long story about the history, physical, past medical history, risk factors, everything else, all comes raveling out. And it sounds good, and then at the end of it he says, so I think this is musculoskeletal chest pain, and I think we can send her home with some ibuprofen. It's a System 2 slam dunk. It looks perfect, and kind of depends on who I'm working with, but often I find myself saying, this sounds really good, what you've done is good workup, everything sounds good, you're probably right, I just want to go and have a look at the patient. And what I rely on when I look at the patient is that some sort of subtle, covert pattern is going to present itself that's going to say, don't do this, or yeah, this is okay. So the question is, how do you train that? How do you train it? And the answer right now seems to be just practice.
And that's been shown over and over again, right? That all the tests, Gestalt or experienced physicians, what they feel is going on is the best test by far. If you feel like something's wrong here, persist. If you feel like it looks great, like you said, from the end of the bed test.
We have time for one more question.
I'm an interloper, Mark Goldschmidt from Internal Medicine. I've spent a lot of time chatting with Jeff Norman and Georges Bourdage about some of these same topics, and I also do some research in this area. I have at least 3 areas I'd like to kind of discuss with you, but I'm going to only focus on one of them because of our time. And that is this assumption that because we spend so much time in System 1, obviously the majority of errors are going to be in System 1. I mean, that's partly true, but that somehow System 2 comes across the way you're presenting it as being therefore better. And I would say that when I find myself in System 2, the first thing I start to do is say, uh-oh, I'm not an expert in this area because I'm not recognizing a pattern. I do agree, and I think the main point you're making is that System 1 is important. It allows us to be efficient and effective, but we have to balance it with System 2. But there's a piece of message that suggests that we make less errors in System 2, and I would suggest if you start in System 2, you've already recognized you have a problem because you're not recognizing the patterns. And so I think there's more discussion that needs to come around that, perhaps.
Yeah. Yeah, I don't argue with that. I think this, as you're probably aware, there's been quite a debate in the literature about this, and my position has become polarized against Jeff Norman and some of the people he's worked with. And his most recent email to me, we're still on talking terms, is that he's going to back off. And I'm happy to hear that. I really, getting back to Derek's point, I really don't want to polarize it. I really don't want to say, but what I can tell you is that in 30 years of emergency medicine, when I've seen things go catastrophically wrong, it has not been because people didn't have the knowledge, or they were lazy, or that they ended up trusting their intuitions at the wrong time. We actually have a manual that we use for teaching clerks called the Cognitive Autopsy Manual, and it is a big document of about 35 cases which are analyzed in excruciating detail for the cognitive errors. And I respect Jeff Norman and his work, but he's not a clinician, he's never worked in this environment, and he never will. And I think that's the main failing of some of the research that's done in decision making, is that it's to have somebody, a newly graduated physician, sit in front of a computer screen and make decisions about data that is complete in front of them on a screen is just a different world from the one we live in.